Thank you very much. I hope you've been enjoying the program so far, and I certainly have. And so I'm just so excited for this symposium and for our last speaker. So Elridge Proctor, I will turn it into to you, please.
Thank you for that, Omar. Let me just start by welcoming everyone back from our short break. Again, to give you a quick introduction, my name is Elridge Proctor, Senior Director at Government Affairs at Go-To for Lung Cancer. We recently changed our name where we took out the foundation, so I'm still remembering to not say foundation. Go-To for Lung Cancer, there you have it. So this session is Patient Experience Healthcare Metrics. This is where we get to continue the conversation, the discussion, where you can ask your questions about where smartphone and smartwatch health data are stored. This is where you get to ask questions about how stored data is being used and who's using it. This session will explore the science of digital and personalized data and patient-centered quality measures. And to give this presentation, I'm excited to introduce Dr. Brian Anderson, Chief Digital Health Physician at MITRE, where he leads research and development efforts across major strategic initiatives in digital health to architect, implement, and analyze health data and information systems for industry and various federal agencies. Dr. Anderson is responsible for co-founding the Coalition of Health AI, or CHI, and the Vaccine Credential Initiative, also known as VCI, a coalition of more than 1,000 organizations assembled during the COVID-19 pandemic to work towards interoperable and verifiable clinical information, leading MITRE's development of machine learning techniques to leverage real-world health data and linking genomic and clinical information to provide insights into the efficacy of therapeutics and vaccines. Prior to joining MITRE, Dr. Anderson led the informatics and network medicine at Athena Health, where he launched new model of clinical decision support leveraging artificial intelligence. He has also served on several national health information technology committees in partnership with the Office of National Coordinator. Today, Dr. Anderson will spend time focusing on not only metrics, but also care coordination, the digitization of health data, and how the data is ultimately used. I'm pleased to present Dr. Anderson.
All right. See, Elridge got my notes from my mom with that introduction. Thank you, Elridge. You promised it was going to be short. Before I get started, I just wanted really to thank Omar, Randy, Lillian, Silke. You guys, this has really been a fantastic symposium and summit. I feel like personally I've learned so much and been inspired. I had the pleasure of sitting right next to Tanisha, one of our patient advocates, and the stories of perseverance that are just throughout this room and embodied in the experiences of so many of you is inspiring. It's the reason why I went into medicine and became a physician myself to put patients first. Literally, it's on your logo for the National Health Council. It's just truly fantastic. So thank you for having me and for being here. I wanted to start talking a little bit about this book. So in 2015, Dr. Bob Wachter wrote this seminal piece on digital health, the digital doctor, the hope, the hype, and the harm. And in the book, he really sets out the trajectory of where all of this is going as it relates to the generation of data. And this concept of ever-increasing digitization of one's health data in healthcare and the use of that data for any number of use cases, many of which have been illustrated here today. When I speak about digital health, I oftentimes talk about this concept of inevitable futures. And certainly one of those inevitable futures is this idea that more and more of what we do is going to be quantifiable and used for metrics, for algorithms, for the ability to infer causation as it relates to whether or not some type of outcome is going to be beneficial to you or not. Any number of use cases. Inevitable futures. One other one, of course, is patient empowerment. How do we enable individuals to have greater autonomy, greater agency in how they make decisions in a shared method with their provider or with their clinician? And yet, in spite of all these inevitable futures, I give you a number. The number is 48. Probably don't know what the meaning or relevancy of that number is. 48 is the average life expectancy of a Native American male on the Pine Ridge Sioux Reservation. 48 years old. That's only 2 more years for me. And that's a really sobering statistic. Why? Well, one, just on the face of it, the average life expectancy in the US is closer to 78 years old. That's 30 years difference. I'm Native American myself. My tribe is the Southern Ute. And so it has a great deal of personal significance as well, both for what that means for me, for my family, for my community. And so I want you to hold those two concepts in juxtaposition, in tension here as we delve into this topic. We're going to come back to what all this means when we have this inevitable future of increasing digitization of data, increasing empowerment of individuals as consumers, as owners of their own healthcare and their own health decision making. We have this concept of individuals that are being left behind. Now I'm reminded of the quote, I didn't plan on using this, but I'll use it shamelessly. Dr. Califf shared from Ed Young in The Atlantic that digital or technical solutions oftentimes find their way drifting to the penthouses of society, while epidemics find their way into the cracks at the bottom. There's a real truth in that. And so what I want you to hear today in my presentation is really a call to action as patient advocates, as organizations representing patient advocates. It is so important for us to have all of our voices at the table when this data is being generated and when this data is being used. I think, Adrian, you asked the existential question. I don't know where you are, Adrian. You asked the existential question of how do we use this data if it's simply not there? I think the sad reality is that you can't. It's really hard to. There's certain methods of imputation that you can use. You can try to infer what that data might be, but there are ultimate biases that you just can't get away from. And so it's so important as we consider this inevitable future of the digital doctor and ChatGPT and all of the hope of all that, that we bring people together to have a voice at the table. So taking a step back, I have the immense pleasure of working at MITRE. Probably many of you have not heard about MITRE. MITRE is a not-for-profit. We run federally funded research and development centers, which means during the pandemic, I had the pleasure of working very closely with the White House COVID Task Force and Operation Warp Speed on all of the critically important questions that we were trying to answer as a society about the natural disease course for the SARS-CoV-2 virus and basic questions about what therapies work and what therapies don't work and what communities are most at risk of being affected. These were basic and urgent questions that we stayed up late every night struggling because we didn't have the data to answer these basic questions. And specifically, and I think to the point for this presentation, we didn't have answers or data to questions about some of the most vulnerable populations in society. Populations like those Native American communities that I mentioned at the beginning, Hispanic, African American, rural communities, inner city communities, all of these communities that are left out of that data collection that so many of us have the pleasure of taking part of. The other thing about pandemics, you probably have heard this, is they accelerate those things that were already on a trajectory moving forward before the pandemic. And there's a lot of good things that come out of that. And so one of the things that the COVID pandemic has certainly accelerated is this concept of, and we touched upon it in the telehealth component earlier today, of medical wellness at home and hospital at home. The hospital at home is really, a matter of necessity. I still remember when we had calls with the CEO of Best Buy, and we were talking about this novel concept of taking the Geek Squad and putting them in hotels and other places in people's homes, using their expertise to bring a hospital to home, something that no one would have thought we would be doing so quickly, but yet the pandemic, because it had the accelerated demand to make that possible, we were able to do that. Additionally, this idea of meeting people where they are at their home, in a medically well framework, enables individuals to have better access to the kinds of care that they might have struggle if they have to take 2 bus transfers to get to a clinic that might be 30 or so miles away, or if they're in a rural setting. The ability to meet patients where they're at, profound implications to what that means from equity perspective, as well as improved clinical outcomes from some of the more traditionally unreached populations. So a lot of good things have come out of the pandemic. And with that, the ability to capture additional kinds of data to be used in metrics, and being able to use those data also for machine learning models. So this is a story I love to tell, so bear with me. Anybody recognize who this gentleman is? If Katie were here, Katie would know. So exactly. So this is Dr. Peter Marks. So I shared in the pandemic, I had the pleasure of working with Operation Warp Speed. Little known fact, Peter is a diehard Star Trek fan, and he came up with the name for Operation Warp Speed, as you might imagine, because of a Star Trek fan. So I remember this one time when Peter and I had a conversation in the winter of 2020. This is the time when 4,000 plus patients a day are dying. And he was pounding his fist on his desk saying, Brian, why do I have to rely on data from Israel or the United Kingdom to get urgent answers about whether or not the therapies, the interventions are working or not, that we, the FDA, that we, society, are trying to get these urgent answers to? I had no good answer for him. The way that we capture data in the United States as part of clinical trials, it was clear that in this pandemic that was not adequate. Many lives were lost because the kinds of trials that we stood up, the way we went about doing the clinical research, it was too slow, it was inadequate, it did not include the necessary diversity of patients that we wanted to have be part of this kinds of clinical research. So Peter had every right to pound his fist on the desk, asking for those answers that late night in the winter of 2020, because 4,000 patients a day were dying. But one of the things that we learned coming out of the pandemic, and certainly I think was impressed upon me from many of those conversations with Peter, and Peter, by the way, is a hero to me. He's just done tremendous work within CBER at the FDA, is a rethinking about what it means to leverage real-world data or real-world evidence generation. Now, Dr. Califf didn't talk about it when he was up here, but one of the things that he really led the charge during his first tenure as commissioner was this idea of evidence generation. He had this whole initiative around evidence generation and looking to find ways to leverage real-world data as real-world evidence. Because as I was sharing earlier, these complex, highly intricate protocols that we traditionally use to go about clinical research oftentimes disenfranchise whole communities of people. And usually, the people that are part of clinical trials are urban, wealthy, well-connected individuals. They're not the underserved, not as well medically literate or connected individuals that we want to have part of clinical trials. And yet, I come back to that inevitable futures concept. In this framework, more and more data is being collected about all of us when we're in our doctor's office, when we're wearing our Fitbit or our Apple Watch, when we're at home using one of our smart devices. The opportunity to collect that data and use it for good is tremendous. And so, again, I have the pleasure of working with many of the leadership in the FDA and within HHS, and one of the things that we're thinking about is what does real-world evidence generation 2.0 look like? Now you can see up on your screen there's different categories, but the one that I want to focus on today is the patient-generated data. So remember that individuals not only are becoming more empowered to own their data, having the agency to decide who they want to share that data with, they have the ability to interact directly with researchers, with physicians, with clinicians in novel ways. In the pandemic, we had patients talking directly to clinicians, to public health officials in ways that had never been imagined before. And so this concept that many of you have probably heard about patient-reported outcomes becomes really powerful tool when we think about how to engage patients, your patients that you represent, in things like clinical research. Now, we had a wonderful panel up here earlier, and Dries mentioned this question about, well, like, if I needed to ask the 50, 60 million diabetics a question, I can't do it. But wouldn't it be great to be able to do that? It would be. It'd be fantastic. Now, I'm not saying that the future of medicine is going to be where we can ask all 50 or 60 million people. But the challenge, and again, this is the challenge to you, is to help drive action within government and within the research institutions that fund this kind of research to stand up the networks of information technology systems that actually allow us to take advantage of those PROs so that we can actually ask a really diverse cohort of people. There was a study that was published out of Stanford with Apple that leveraged the Apple Watch and the EKG sensors that they have on it. If you look at the study, the number of people that were involved in that study was mind-blowing. Tens of thousands of people. The ability to directly reach out to and partner with individuals as part of a clinical trial and research to get a better understanding of whether or not a therapy is working specifically for an individual or for an individual population is the promise, maybe somewhat the hype, but certainly the promise of personalized medicine. That ability to have a diverse set of populations that you can reach out to and work with. And so, when we think about, where all this is going, I apologize, I didn't know what to do with the red there. The hope of all of this is that we're going to improve the overall life expectancy, the quality of life of individuals in our society by using this novel kind of data. So a little bit of reality here for a moment. This study comes from the Integrated Clinical Systems Institute. Much of the other literature out there shows the same, which is that roughly 80% of the features that influence one's overall life expectancy or quality of life are not the things that we spend $4.3 trillion on that Dr. Califf had talked about in healthcare. That's only 20%, right? 80% of it is what we commonly refer to as social determinants of health. There are the behavioral, environmental, socioeconomic, deterministic effects that go into whether or not I'm going to lead a healthy lifestyle, whether or not I have a high risk of getting a particular chronic disease. The promise, though, is that, our society is filled with a lot of smart people. And certain organizations, certain innovative startup companies are looking to drive down that cost of healthcare by quantifying the 80%. How do we get that kind of data? How do we get the multimodal data that is able to roughly, in a privacy-preserving way, know where you are, what your zip code area is, layer on top of that the distance to a grocery store that might serve fresh fruits and fresh vegetables, your access to mass transportation, perhaps some inferred information about the socioeconomic status or the home ownership status, and using that data to help build better models, better insight into the kinds of care that individuals should get. Now, there's promise in that. There's also peril, right? The peril came up earlier is like, how do we ensure that we as individuals in our society have a right to our data, to share our data with whomever we want to share it with and not share it with whom we don't want to share it with? I, for one, certainly don't want my data just out there in a fully identifiable way for these algorithms to use, even if it would be beneficial. I'd want to be able to have some agency, some choice over doing that. And so I think that's where it's important. And I think, Dewan, you had asked a question, I think, really around this is, how do we ensure that individuals or the organizations that represent individuals have a seat at the table to ensure that there's that kind of privacy over that data, while also ensuring that that data is used for the right, appropriate, trustworthy ways? And that's a question I want to come back to. But it's important to note that organizations, Optum is a great example, where they're using a lot of complex data layered on top of one another to help infer or inform that 80% that is deterministic and not necessarily just relying on the 20%. Dr. Califf had mentioned this a little bit, and I think some of our other panelists had spoken about decentralized clinical trials. I think there was, just last week, draft guidance published, updated draft guidance on decentralized clinical trials. This is a wonderful space for patients to participate with researchers that come from communities that are traditionally not participatory in clinical trials. So what are decentralized clinical trials? They're essentially trials that aren't confined to the brick and mortar health systems, the Quaternary Referral Center in downtown Boston, where I live, that you have to have access to a car and $50 or sign away your mortgage if you want to get parking to be able to participate in. Decentralized trials happen, just as the name implies, in places that aren't centralized. So the ideal decentralized clinical trial, if you were to ask me, that the FDA would fund, would be one where the majority of the interactions are actually occurring outside of a clinical building. It could be in a telehealth space. It could be in a patient portal. It could be in a manner in which that is most suitable to the patient, meeting the patient where they are. Now, the challenge is, how do you trust that data that's generated? Doctors, I can say this because I am one, like to be, I think, very paternalistic. And, I can't trust that data because I didn't type that in or I didn't capture it. That's a fallacy that decentralized clinical trials, if they are to be successful, needs to turn on its head. How do we create the kinds of data that our patients can generate in a decentralized clinical trial from their home, in a medical wellness setting like their own house, that can be trustworthy, that can have the kinds of provenance or the ability to audit and track it so that you know where it came from and you can trust that data? So how can that kind of data be generated? Well, so one of the things Elridge kindly referenced that I, along with a wonderful group of collaborators, helped to start was this effort around smart health cards. The effort was called VCI, or Vaccination Credential Initiative. And it was a tremendous journey with a group that started with 12 and it hasn't ended. It's continuing now. It's over 1,500 different organizations. Smart health cards really are about empowering individuals to have access to, ownership over their own health data. You may have one of these. In the pandemic, you could have gotten, if you were in Virginia and I think in Maryland, a vaccination card that was a QR card. Our group came up with that, and we're pretty proud of it. Now, putting aside the political contention there, at its core, what this effort was about empowering individuals with a trustworthy, provenance-enabled QR code of their health data that they could display on their mobile device. And I think, as Nicole had shared in one of her slides, it is not an accurate statement to say that only wealthy people have mobile devices. The penetration of mobile devices across all spectrums of socioeconomic status is pretty significant. I don't know if you caught it, but it was 76% at even those under $30,000. So when we thought about how do we engage individuals in an equitable manner, we wanted to go and use mobile-first technology because that is really a manner in which we can meet people where they're at, While also simply, we created a little sticker so those individuals that don't have a phone, they can certainly have a sticker that they can put on a card. But it's important to point out that equitable solutions oftentimes can be found with mobile devices, and so certainly that's where we started. The hope of all this, where we go with this and the FHIR interoperable standard that we created around it, was to take this incredible effort that ended up with more than 225 million people in the US having access to it. I think it's 500 million people worldwide, is to take this and grow this beyond just the VCI world of vaccination credentials, but into this concept of QR to the max. This is what we jokingly refer to it with the Office of the National Coordinator. There are so many use cases beyond just vaccination credentials for a smart health card or a smart health link or this QR code. From your complete health record to various segments of your health record, to insurance cards, to patient-generated data, patient-reported outcomes, empowering, again, individuals to have their own data, to have provenance over their own data, to be able to share their data with whomever they want, with a research institution that they want to participate in a research trial. This is the future of where these two efforts of the increasing digitization and patient empowerment, I believe, are coming together. And so when we talk about metrics and enabling the use of those metrics for equitable, fair, responsible ways, when we talk about generative or predictive models in AI, it's really about using technologies like this to empower individuals to share their data in a more open format so that we can be more inclusive, so that segments of our society that, again, traditionally are left out are able to participate more. Now, I wouldn't be a speaker up here if I didn't talk about ChatGPT. So I have to have my one slide on, or two slides actually, I have two. So generative pre-trained transformers and GPT-4 in particular, a few words on this. So whenever I speak on generative models, or predictive models for that matter, I like to remind people that all algorithms are programs that are trained on our history. All algorithms are programs that are trained on our history. Now think about that for a minute. I think it was Nicole that had talked about that great, I love the metaphor, eyes in the back of your head. It's so true. And there's a lot of peril in that. Like if you think about the systemic injustices, the racism that is in our history, we're training the state-of-the-art AI on that. And what does that mean for our society? And what does that mean for getting the right kinds of patients at the table to ensure that their data is part of these models that are going to be trained? Jennifer was absolutely right. These models get worse over time. Some of the initial work that we've done with Microsoft and Google show, inside of a month, the AUC score of these models goes down fairly rapidly. And so there is both a need and an opportunity to revisit how these models are trained to ensure that we're including the right segments of the population. And so, I want to come back to a question that was asked, I think, in the last panel about how do we ensure that patient advocates, organizations that represent patient advocates have that seat at that table to ensure that that data that's being used to train these algorithms that are being trained on our histories is equitable, is mitigating unjustified biases, is addressing the systemic racism in our society. I believe that one opportunity is through this coalition that a number of us founded. It's called the Coalition for Health AI, or CHAI, like the spiced tea. We published earlier this year a blueprint that described a set of core principles that we believe are critical for the development of any models, for the implementation of models, and the longitudinal governance of those models over time. If you've seen the news, you've seen probably some of the polls that show the majority of United States citizens do not trust AI. And it cuts across all political spectrums. There's a little bit of an age bias. Younger people trust it a little bit more than older people. But the majority of Americans do not trust artificial intelligence. There's probably a good reason why, what I was just talking about. Those histories that they're trained on, I don't know if I would want an algorithm that's trained on how my people have been treated to be used on me. Would you? Probably not. And so what we're trying to do in CHI is build a public-private, and I'm intentionally using the word community, partnership here. This group started with a set of academic institutions, Mayo, Johns Hopkins, Emory, Duke, tier 1 academic medical centers. Fantastic, very strong in the AI machine learning space. It started with technology companies, the largest in the world, Microsoft, Google, SAS, these companies that are at the forefront, innovating, in the news, developing these tools, wanting to come together to build out a set of shared principles and best practices that the industry could adhere to. What wasn't part of that, and to this day, that I still believe we have an urgent need to include, are patient advocacy groups. We need patient advocacy groups at this table more so now than we ever have in the past. Now, we have one or two, but that's not enough, nearly not enough. We don't have enough ethicists. We don't have enough patient advocates. Duan, this is, I think, my answer to your question of how do we get the right people with their voice to the table to help build this consensus-driven set of best practices on how you govern AI, how you approach understanding and mitigating unjustified bias, how you build transparent testability so that you can monitor the AI to ensure longitudinally the AUC score is good. You have to have them at the table helping to build out those shared set of principles. And we're very excited. This coalition we launched a year and a half ago in the private sector quickly got a number of representatives from the federal government. So the White House, OSTP joined, the FDA, the ONC, NIH, a bunch of organizations, I think, within the federal government appreciated that this is an opportunity to come together in a public-private community partnership to build out this consensus-driven set of best practices. And so the last call to action I'll leave you with is that please consider joining this effort, because really, I come back, Adrian, to your question, we need to lean in and enable our patients to participate in this next set of, or this next stage of innovation in digital health, where that data needs to be there to ensure that these AI models are being trained appropriately and equitably. But we need to generate that data in a way that's safe, privacy enabling, and assures the autonomy and agency of the individuals that rightfully own it, that have the concept of data dignity, that have the ability to own that data and to determine who they want to share that data with. All right, so that's it. Elridge, I think you're coming back up and we're having a conversation. All right.
Okay, that was great. Let me start off by thanking you. Thank you so much for talking to us about patient-generated health data post-pandemic. I have several questions, but before I forget, I'd like to invite the audience, so please step to the mic and share your questions too. I know Dr. Anderson would like to hear your thoughts. So to start, let me just share that today I've heard you convey a very strong message that health data is about empowering individuals to have their own health data records and for patients to tell their own story. And to underscore that, several years ago, President Biden called access to health data records a matter of life and death when he struggled to have his health records sent for his son, Bo. His administration today continues to work on eliminating technical roadblocks that prevent patients from obtaining their own medical records. What more can you tell us? And specifically, what can you share about the acceleration of health data digitization during the COVID-19 pandemic?
Yeah, so share a few things publicly. So in the State of the Union this year, President Biden talked about an initiative around pediatric cancer navigation. One of the truly exciting things about working at MITRE is the opportunity to work with very senior parts of the federal government. And in this particular case, what was publicly announced and shared is a collaboration being led by the National Cancer Institute that really looks to create the kinds of partnerships and technologies so that no one ever has to have the same experience that President Biden and Dr. Biden had with their son. When Bo had an initial diagnosis, it was nearly impossible for them to get his cancer records from the place where that diagnosis was initially given to a referral center where he would ultimately get the care, the cancer treatments that he needed. And so similarly, what President Biden envisioned and that he described in the State of the Union was a navigation service that would create a network of navigators that would allow individuals that, families that are having the worst day of their life, really, when you have an initial diagnosis, to be able to partner with a navigation service to enable their data where this initial diagnosis is coming from, to be able to get to the right comprehensive cancer center in the pediatric setting to help deliver the best possible care, to identify the kinds of clinical research trials that those individuals can be enrolled in. And so what we're doing at MITRE is helping to build that network and create those technical capabilities to empower those navigators to be able to really, the NCI's mission is to get the best kind of research to bring it to bear for these individuals. And again, it's those patients' data. It's their families' data, and enabling them to get that data from point A to point B as easily as possible in one of the most traumatic periods of a family's life is a really important, noble cause, I believe. And so, we're really excited to be partnering with them to do that. We just started it, so more to come probably in 12 or so months. But that's one of the exciting things that we're doing.
It's impressive. I don't know if anyone has anything to add to that, but I've got another question, so I'll just keep going. But again, we invite you to the mic if you have questions or thoughts on that. So another question, let's go back to metrics, right? Can you talk to us about how patients or patient advocacy organizations have been invited in helping to design the metrics or ways that they're helping with positive outcomes to be measured?
Yeah, great question. So when I put up the slide on the different kinds of data that is used, there's a whole set of different kinds of data outside of the healthcare specific data, right? There's socioeconomic status data, there's location, there's race, ethnicity kinds of data. And when you're a technology company, and I won't use any names here, but when you're a company that has access to this kind of data, and you want to build an algorithm, I'll use an example, a Medicare Advantage model that helps you identify, who is likely to have a bad outcome for breast cancer. There are going to be certain features of that data that you're going to want to test, and you're going to want to potentially include in that model to help identify individuals that have a bad outcome for breast cancer, so that you then, as the company, can then take the proactive steps to reach out to individuals that might have those bad outcomes before they have those bad outcomes to take some kind of intervention. There are a lot of examples where those companies chose data or features that might have been inappropriate. An example, should you include religion? There's an example out there of a company that chose religion to be one of those features. That's an opportunity for patient advocates, for patient advocacy organizations to, again, as I was talking about earlier, to have a seat at the table, to really engage in that kind of conversation. What are the appropriate kinds of features to include in building these metrics and building these models that inform, something that we all want to have done, but it might not be the right feature or the right metric to include.
Yeah, that's interesting. I struggle, and I'd like to ask you this question because I think it's still true. Do you agree that patients do not fully understand the role that machine learning is playing in their healthcare? And I think about often the settings where I'm at the doctor's office and I have all the intake forms and I've got to answer all these questions, and sometimes some of the questions I'm not sure how much of it I want to disclose because it could be very private, sensitive information. And so when providing some of this, I think the first thing that comes through to a patient's mind is whether or not they will be discriminated by their insurance company. And so I wonder if you have any assurance on how to go about sharing information and the data that you're providing to your healthcare team at that time in that setting.
Yeah, I mean, I think sadly the answer is right now we don't have that assurance. And what we desperately need, and I think what society rightfully is appreciating, is a need for a better kind of regulatory framework that takes into account the use cases, the incredible power and capabilities that these models are able to bring to bear. Because I don't think any one of us, I mean, I feel like I'm pretty educated in this space, and I don't have a full appreciation of how my data is being used. And so I think it's really important that our elected representatives and we as a society come together around, what that framework should be. Barney Frank, a famous representative from my home state, Massachusetts, once said that, all government is something that we as society decide to do together. I think this is something that we as a society really need to come around and do together, because the points that you're raising, Elridge, are really, central to, core values in our society of autonomy, of agency, of privacy, how you are going to use my data on me without me not knowing how it's being used. Those are important equities to consider that I don't think we have the right kinds of framework in place yet.
Yeah, and I'll follow that and just speak to some of the privacy concerns and storage issues. This is a tough question, so you can answer it as best as you can, but I really want to know if a patient changes their minds and would like to either change, remove, delete their data, can that be done?
So today, not easily, if at all. I'm not a lawyer, so I don't want to get out in front of my skis too much, but as a clinician, the way that we store data, in our EHR systems where we work, and then we generate notes and we share those notes with our patients. And oftentimes, if you're a forward-leaning health system, you can have something like open notes, and you can share very openly with your patients what's in your note. And sometimes the patients may write back and want to edit something. But the concept of taking that data and owning it as we might think about owning something else doesn't exist in the health system framework. I would argue that we need to think more closely about that, particularly when we have so many use cases out there about how this data is going to be used and decisions made about whether or not we're going to get coverage for something, whether or not a claim is going to be denied. There's recent news about things just like that. And individual society don't have any power or agency to really take that data back and say, that's not right, that's not accurate, or I don't want you to have that data. I think there needs to be a lot of work done.
Yeah, thank you for that. I would like to recognize the question on the floor.
Overton with Merck, and I'm on their Patient Innovation and Engagement team.
Hi, Lisa.
And we're all very interested in the collection of data, of course, but I have two parts to this. During COVID, you mentioned the QR code and what was presented. How many people participated and received those codes, in a time when, in order to move, you needed that? So if you have that data to provide, that's of interest. And then on this side, when you want this as a patient, they may not feel it's relevant to give you this. So bringing them to the table now instead of having them at the table earlier to understand their wants, their needs, their desires, it sounds like what's in it for you, not what's in it for me.
Yeah.
So that's a different perspective. So those are the two parts. I'll sit down and...
Appreciate the questions. So to your first question, the rough estimate that we have was 225 million individuals in the U.S. Downloaded copies of their QR codes across the 27 states in the U.S. Your second question is a really important one. it speaks to a few principles that I think, looking back and reflecting on what we did in VCI, that we could have done better. I think one of them was include patient family advocacy councils, patient advocacy groups at an earlier stage in the development of the technology. I think this is true across any technology that's developed, is the importance of including the right stakeholder audience from the very beginning. When we created that technology, we wanted to create an ability for individuals to safely get back to work. The important example I oftentimes reflected on and used was, on my reservation, it's a service-oriented space with lots of casinos, restaurants, and those bartenders and busboys and maitre d's and waiters and waitstaff I want them to have a safe environment to go back to work in. And so helping to enable their patrons to demonstrate, yeah, it's safe for me to go and eat here or go there and do that, was an equity and a use case that was really important to me and to many of us. And so I would say that we tried our best to create a solution set that addressed some of the inequities that we saw in certain segments of society, but it wasn't perfectly done. So I agree, there's opportunity there.
I want to piggyback off of what you had said, Eldridge. For me, I live with devices. I mean, I have an insulin pump and I have a continuous glucose monitor. I remember vividly, probably a couple of years ago, I took a pump break. I get tired of devices. We all do. And so when I went back my endocrinologist went back to try to get prior authorization for that insulin pump, the insurance company denied it because it saw that I went on an insulin pump. That I went on a pump break. So for me, right, as, once again, 24/7, 365, it doesn't go away. How can AI or et cetera stop an insurance company from telling me that I can't have something because I was protecting my mental health because I needed a break? So that, from that standpoint, scares the mess out of me, and why I don't disclose anymore that I'm going on a pump break. I say, hey, just in case my pump breaks, I'm going to need some extra insulin. Yeah. So those are things that, and I'm just saying it just to say that as patients, we have to protect ourselves. And diabetes doesn't go away just like a lot of other conditions. So to be penalized because we took or someone takes a break, it's not fair. And those are things as patients that we think about, where people like you who have a functioning pancreas and you don't think about these things. It's disturbing, it's hurtful, it's disappointing, and it's deflating.
So just a comment to that. So one, thank you for sharing that story. It's frustrating. I really appreciate you sharing it. A solution, I think, can be found in this concept of transparency in how we generate and create models, predictive models in particular, rely on a set of features that go into black boxes that are hard to explain. But what you can explain are what those features are. And if one of those features is whether or not you were on or off an insulin pump, you then have a level of transparency to work with the owner of that model to really have honest questions and hold them to account if that's a right feature you should include because of the potential use case that you just described. And so what we're trying to do in CHAI is to create that kind of transparency of what are you doing to create the models that you're using? What are the inputs? What are the outputs? And to transparently work with organizations like payers that deny claims to hold them to account, to transparently show what those inputs and outputs are. Because I think with that kind of sunlight, the hope is that we'll create a level of trustworthiness that these models are actually being used for us and not against us.
So this is to follow up particularly around the validation of measurement tools. And specifically because we know that proms are used in insurance environments and claim submission processes. And so if we're going to ask our communities to trust us when we're going to talk about how we might be able to advocate for a policy by utilizing patient-reported outcomes measures, and these AI systems are taking the historic data that's been validated, the process has been validated, but it's being provided to a patient in a room who says, you just have to fill out this form, you just have to do it. And she, Megan on stage, said, oh, like what that felt like for me, and I'm a psychologist, right? So, or psychiatrist, apologies. So I think that my question is, if we know that this historic system is broken in patient-reported outcome measures, and then those patient-reported outcome measures, whether collected through through like device technology or in a patient-reported survey, that those are going to be possibly utilized against individuals, how can we ask them to trust us?
Yeah, I think it's really hard to. I mean, this is why Dr. Califf said at the beginning that regulation of these large language models is an urgent, need for our society, precisely because of that point that you just made.
All right, we'll take the next question.
Certainly. I want to actually continue the conversation. Rich Brennan with the ALS Association, and I represent roughly 33,000 Americans that on a trajectory of a very terminal illness. They don't live past 2 to 5 years. But I'm an internal optimist, and I see the needs for technology in improving their lives. But I also, as a policy expert and a technologist here in Washington, D.C., understand that in many respects, governments and corporations and others build technology tools that make determinations on, as we brought up in this room, what types of therapies they're going to have access to, what kind of durable medical equipment they're going to have access to, whether or not they actually, for instance, we've been having insurers deny ventilators across the country for people that are in dire need of them. I think my question is we build, I think my cautionary note is, as we think about these tools and resources and metrics in particular in trying to measure things that make direct impact on patients' lives and even their quality of life, even determining what is their value of their lives. We have, I would say as a nation, as a country, just have to, at the forefront, as we deploy technologies and think about AI and other methodologies, what is, can we build these to be part of the greater good? Can we, as you said, make sure that we're measuring when they are out of sync, when they need to be deployed differently? And I'm also concerned about discrimination. And as far as we've talked about in this room, everybody's concerned about discrimination. And I obviously represent the disabled community. So that's, I think, part of the trust issue that I'm determining across the country is people do not trust things that they don't quite understand, and also they think that it might be already predispositioned against their overall outcome and what they want from their own care providers, their own decision making. They don't want something else to make a decision for them that they can't make themselves.
I know we're short on time. I'll just keep my comment response brief. You're absolutely right. This is our opportunity as society to lean in and help inform how those algorithms and models are built moving forward. If all algorithms are programs trained on our histories, right? If we do nothing, what a waste, what a lost opportunity. We're just reinforcing the systemic injustices of the past. But it's an opportunity for us to lean in, to engage, and ensure that the right stakeholders are at the table so that that DME claim is adjudicated appropriately and not inappropriately. So I'm with you on that.
So I do owe you an apology. We have ran over time, and I must turn it over to Dr. Omar Contreras. But please, please, before I do that, will you all join me in thanking Dr. Anderson for a wonderful presentation?
Thank you.
Wow, just thank you so much to everyone, all the patient advocates, the patient groups. Please give it a round of applause again for everyone here today. I truly walked inspired and energized for the commitment that we've done today in this new space that is complex yet not achievable. So I'm really thankful for all the wonderful speakers and the expertise for being shared today. Thank you, Dr. Anderson and Elridge, for finalizing today. And also just to hear from diverse and impactful group of speakers that included the patients, the caregivers, researchers, academics, and the leaders in the digital and patient engagement world. This was an incredibly robust symposium, and I'm so excited to take back what we learned and apply it to our initiatives at the National Health Council. I hope that the organizations represented here today are excited to be more involved in this work or ready to apply the learnings into their own organizations. The Science of Patient Engagement Symposium has historically been a platform for the scientific leaders and for patient engagement experts to convene and build the consensus on methodologies, on strategies to advance inclusion and the patient voice into research. Today, we learned the importance of being intentional in the inclusion of underrepresented voices and bringing in patient-centered innovation in digital health to move the needle forward in providing quality care for all. Once again, I would like to acknowledge and thank all of our sponsors for this meeting. Also, I would like to say thank you to our Research and Programs Committee. That was a large reason of why this meeting was so successful. So thank you again. And of course, we could have not done this without the amazing National Health Council team. So I would like to take the time for the staff at NHC to please stand up to give them a round of applause for all their work. Thank you very much. And also, if you haven't learned anything, Siri could do many things as well as Google and Alexa. So please ask them to mark your calendars for the 2024 Science of Patient Engagement Symposium, which will coincidentally fall also on May 8th, 2024, here at the historic National Press Club. So we'll be coming here again exactly in a year. And before we move on to the Holman Lounge for the reception, and as a friendly reminder, as Dr. Anderson mentioned, there are QR codes, and they are valuable. So those QR codes are placed on your table to complete your evaluation today. So please take the time right now, open up your camera, scan, and it will take you to the link. Your evaluation, is very important for us as it helps us to plan for next year's symposium and identify themes. And it was because of the evaluation from last year that this theme came to mind. So we're just really thankful for that. And also, again, just finalize, thank you everyone for attending our 2023 Science of Patient Engagement Symposium. And now we do invite you to chat, connect over refreshments, and delicious hors d'oeuvres next door. This meeting has concluded. Thank you so much.